Yeah, good afternoon. Myself, Dr. Abhinav. I welcome you on behalf of the Division of Trauma Surgery at Trauma Center. And what I say, in, as we all know, that the JPNATC Trauma Center is the level 1 trauma center of our country. And we often receive patients from who are initially treated at other hospitals to our institute. And these cases, they do come as either it is an informed transfer or an uninformed transfer. But in our country, in our region, most of the patients are an uninformed transfer to their patients. So in trauma management, what is the critical? It is this the timely decision making. What do we say? The timely decision making is the key during the assessment and management of a trauma patients. And this is why it is important, because it leads to the improved overall outcome of the patients. But at times during decision makings, whenever a clinician rely much on the initial investigations or information which are given to you, that what is called the anchoring effect, that leads to the poor decision making. And through this case, which we are going to present in just a couple of minutes, that how we'll share our experience, how unmasking the anchoring biases led to the prevention of the potential catastrophe in these patients. So with that, I'll request Dr. Srishti to come on and present the case. Yeah.
Thank you, sir. A very good afternoon to all. I am going to present an interesting case. So now this case starts with a 13-year-old boy who had a trivial trauma from fall from stairs with impact over chest. So he was initially taken to a nearby private hospital where he was treated and admitted as a case of a blunt trauma chest. So they did an evaluation, they did an HRCT which was suggestive of right-sided pneumothorax, for which they placed an ICD. But instead of blood, what came was a 500 ml dirty white fluid. So whenever we see a white, a milky discharge, our suspicion comes to our mind of a chylothorax. So they had a similar suspicion of chylothorax. So to further confirm their diagnosis, they sent biochemical markers which came to be positive for triglycerides, further collaborating their suspicion. So for further confirmation, they did a dye test with green dye and they saw that the dirty white outpost is mixed with a green tinge, further confirming their diagnosis, and the cytology also reported that fat globules were present. So they diagnosed it at a case of a blunt trauma thorax with right-sided chylothorax, and they treated him for 6 days in their hospital. But the ICD output was increasing day by day, so they referred the patient to our side on post-injury day 6. So this was an informed transfer with under ABC S-bar protocol, in which everything was patent, breathing was spontaneous, he was maintaining saturation on 4 liters oxygen, CCT was positive on the right side, he was hemodynamically stable, diagnosed as a case of outside, as a case of right-sided chylothorax with already ICD in situ, with a background of fall from stairs with impact over chest. An assessment of a pneumothorax with a query thoracic duct leak and suggested for a thoracic duct leak intervention, transferred by a private ambulance. So the patient arrived at our site on post-injury day 6. We did a primary survey in which the airway was patent, C-spine, they've already ruled out. Patient was maintaining saturation on a minimal oxygen of 5 liters. Patient was tachypnic with a 22 per minute, and air entry was decreased on the right side with already right-sided ICD in situ and was draining dirty white fluid still. Patient was hemodynamically stable, PCT was negative, had a full score GCS. So we did an adjuncts EFAS was positive in the right-sided thoracic cavity. Chest X-ray showed that there was right-sided haziness suggestive of a collection with underlying lung collapse with pneumothorax. Pelvic X-ray was normal. On secondary survey, there was no significant past history. Only history was fell from stairs and no other injuries were noted. So we planned, so patient had also brought HRCT outside film. So we admitted the patient as a case of blunt trauma chest with right-sided chylothorax, and we reviewed the HRCT with our radio diagnosis department, and no other new findings were there. So we planned the patient for a non-operative management. We decided to repeat all our lab works and also repeat the triglyceride and microscopic analysis of pleural fluid. And in the meantime, we started the patient on medium chain fatty acid diet. So this was post-admission day 1 and injury day 7. We repeated the X-ray. X-ray still showed the signs of a pneumothorax with a collection, with collapse. ICD is still having high output, 500 ml. So why was this collapse? ICD was draining higher, ICD was draining, it was 500 ml, there was no air leak, still pneumothorax. So we decided to change the ICD, and in the meantime, TLC also showed that the patient had high TLC. This was post-admission day 2. This was after we have changed an ICD. Still the picture is same. And the triglycerides which we sent at our side was also positive. And this was the post-admission day 3. So 9 days have passed. Chest X-ray is remaining the same. We have repeated the investigation. Triglycerides also positive on our side, but the pneumothorax is still persisting with the collapse. So what are we missing? What are we not identifying? What is there which is staring in our face, but we are not still able to identify it? Why is this pneumothorax still persisting? Is it a loculated pneumothorax? Or is it a lung collapse? Could be. Or are we missing something in this picture? So we started again from the scratch. We reviewed our history and we rediscussed with the primary team, and we noticed that the patient had a midline chest comfort, pain on swelling and regurgitation from day 1 of the injury, and which was overshadowed by the milky white output. When they did a green dye with the full cream, that dye immediately came into the ICD. Why? It should have traveled through the circulation. This ICD output was increasing, but the repeated triglycerides were low. And the only imaging which we had to review were outside HRCT films. So we thought hard, what was missing? Did they rule out an esophageal injury? No. So we planned an esophagogram for the patient. Now my colleague Dr. Puneet will discuss the CT further.
So CT thorax with CT esophagogram was done for this patient, and in this is the axial section and this is the coronal section for the same. In this we can see there is a right-sided moderate amount of hemothorax with the significant pleural peeling, and moving craniocaudally we can see this is the ICD tip, right-sided ICD seen in situ. This is the pleural thickening or significant pleural peel over the overlying right lung parenchyma. And what we see the most significant finding, there is a significant positive oral contrast extravasation seen adjacent to this esophagus, which is tracking and going down into the right pleural cavity. This is suggestive of there is a definite esophageal injury is there, possible site in the mid esophagus level. This is the positive oral contrast which is seen in the right pleural cavity. Moving to the lung window, in the lung window we can see there is a moderate amount of pneumothorax is there on the right sided, with this is the significant pleural peel over the right pleura with underlying collapse of the right lower lung with basal atelectasis overlying the right lower lung. So to summarize, there is a right-sided moderate amount of pneumothorax with right ICD in situ, and there is a and the esophageal injury was confirmed on this CT esophagogram.
Thank you. So this was indeed an esophageal injury which was missed primarily. So now this esophageal injury was hidden by the diagnosis of chylothorax, which was initially prepared by the treating team. So this we call an anchoring bias, which we usually deal in our day-to-day lives. When we see patients, we initially ask them for their outside papers and we get deviated from the initial diagnosis. So since this was a late diagnosed esophageal injury, diagnosed on post-injury day 11, so we planned for an esophageal diversion, a feeding procedure, and a right thoracotomy with decortication. So on post-injury day 11, patient underwent right posterolateral thoracotomy, in which 200 ml purulent fluid mixed with vegetable matter was noted, and a thick peel was noted. On further exploration, there was a 5 centimeter linear tear over the thoracic esophagus. So now the patient was shifted to ICU. He had a normal course initially. He was still having persistent pneumothorax with the output now which has changed to serosanguinous with a minimal air leak. In late post-operative days, the air lungs also expanded. So this was the initial post-operative period. We had started FG on post-op day 4. The patient was extubated and he was shifted. But this ICD output, which was initially in the decreasing trend, started to increase by the post-op day 14. And it has increased to 500 ml. Now we noted that there was intestinal content in the ICD. Now, what was the reason that this intestinal content was still in the ICD? So we planned for a CT torso with a contrast via FJ. Again, I would like to invite Dr. Puneet to further elaborate.
So to see what's going in the patient, why there is a gastric content in there, the CT torso with contrast via the FJ has been done for this patient. Again moving craniocaudally, and this is the axial view, this is the coronal view. In this coronal view, we can see there is a dilatation of the proximal jejunal loop, proximal to the FJ side, and there is a persistent hydropneumothorax with significant amount of pleural peeling and the right-sided ICD in situ. So this CT torso is suggestive of there is a small valve obstruction with possible transition point at the FJ site at the mid-jejunal level, with resultant upstream dilatation of the proximal jejunal lobe and duodenum, and resultant collapse of the distal ileum lobe, which appears collapsed in this pelvic region. And there is a significant regurgitation of the contrast in the stomach. So the CT torso was suggestive of there is a small valve obstruction with persistent amount of hydropneumothorax and with right-sided ICD in situ, and also there is a peeling of the right pleura is still persisting.
So as my colleague specified that there was a small bowel obstruction leading to a esophageal pleural fistula. So the patient again underwent re-exploration where distal esophageal ligation was done, and the peel which has formed over the lung, he underwent decortication for that. And the cause of small bowel obstruction was a band at the proximal jejunum at the site of FJ. So he underwent adhesiolisis. So now the post-op course, he had gradual expansion of lung. Initially TPN started, then FJ started for further weaning off. He had thoracotomy wound essence, which was managed by serial dressing. So the patient has a prolonged ventilator and ICU stay with the 16 days and 28 days respectively. The patient was discharged after 1 month of surgery with cervical esophagostomy, enteral feeding via FJ, and a total hospital stay of 51 days. Now, the patient was serially followed in our OPD at 1 month, 2 months, until 5 months as he gained weight serially and with a nutritional advice and a serial wound healing. So, at 6 months, when the patient attained a pre-injury weight of 23 and all wounds were healed, X-ray were good, efforts were good, we planned patient for a definitive surgery along with the GI surgery team. So, the patient underwent transhyphal gastric pulla with esophagogastric anastomosis. Post-operative events were all uneventful. On post-op day 7, we did a TIE test by esophagus. There was no leak. Noted. So the patient was discharged on post-op day 8. Now the patient started going school after 2 months of the definitive surgery. This is a 6 months post-surgery picture, and this is 1 year post-surgery picture. Now I would like to call upon my senior Dr. Rajesh to further discuss.
Good afternoon, everyone. Thank you, Dr. Srishti. So we have discussed this case of missed injury, and with all the history and presentation, we would like to briefly discuss about 3 important things that has gone wrong with this patient. And first one obviously being the missed injury, and the second one being the anchoring bias that has caused the missed injury in this patient, and the necessity of a standard protocol that needs to be there to prevent such incidences. So missed injury is an injury that goes undiagnosed during the initial assessment of the patient in the emergency department or after admission to the hospital. This is something that is of serious concern to any patient, especially in trauma patients, because the delay in the treatment and the care will cause a significant effect over the remission of the patient. So there have been studies that have stated a lot about this missed injuries, and there was a literature review in 2008 which had suggested which had recorded that there were missed injuries within the rates of 1.3 to 39% throughout. But these could be prevented by improving the diagnostic techniques and standardizing the tertiary survey protocols. And similarly, there was a 10-year analysis that was released in 2023 from South Africa, which had recorded around 17,000 hospital admissions and 4,000 of surgical procedures that were done. And they recorded almost 1.1% of missed injuries in this entire thing. And these missed injuries shall not just be at the level of initial management. This could be at various levels of care. So initial investigations, the following by the radiological investigation that we do, and followed by even the intraoperative or the post-operative care, then we can find out missed injuries being there. And they had also emphasized that the greater morbidity is there with patients who had missed injury following an operative procedure. And in the same manner, there was a study that was released, there's a three-year study that was released from Saudi Arabia, which had recorded 1.7% of missed injuries, and most of these injuries were all skeletal injuries. This was primarily because these patients, the study population that they had taken here, were all having lower GCS and a longer ICU stays, and these being the independent risk factors for missed injuries. In our data, in our department, we around for the last 10 years, we have around 0.68% of missed injuries, and most of them being skeletal injuries to be recorded. So, why do these missed injuries happen? It is utmost necessary to know the causative factors that is responsible for these missed injuries. So, we would like to say that it is basically three reasons that we would like to classify. That is, one is the patient factor, second being the provider factors, be it the surgeon, physician, or the radiologist, whoever is dealt with the management of the patient, and the third is the environmental factors. So, on patient factors, it could be a lot of things. Basically, the clinical condition of the patient dictates the possibility of missed injuries, especially in patients who were hemodynamic unstable, who were requiring damage control surgery, or patients who had low GCS and patients who were intubated and paralyzed have high chances of having a missed injury. And coming on to the environmental factors, though we are in a level 1 trauma center right now, but in places where it is not, the services are not available, there is a possibility of patients being admitted to inappropriate services, and the lack of standard protocols in those places were all reasons. Third, and the most important thing being the provider factors. So, provider factors is at different levels, being physician and surgeon or a radiologist level. So, we need to have a proper standard protocol over the in an institute to we follow to prevent these kind of injuries. And failure to perform, as what had happened in this case, and inadequate films that we had gotten from the outside hospital were all few reasons why this patient, we had an anchoring bias, and then there was a low index of suspicion because there was already a diagnosis from outside, and it was already a 5-day-old injury. We didn't think more about the other possibilities of injuries, and there was this kind of cognitive bias that was present in this patient that had led to the missed injury here. So, cognitive bias is something where there is a deviation from the norm, where we are biased because of the information that we previously have, where we don't look upon any more objective input that has reached to us, rather than thinking about the subjective realities. There are multiple cognitive biases that have been described in literature, and in this patient, what went wrong was because of the anchoring bias. Anchoring bias is where there is a focus on the initial information. A single piece of information will biases towards the diagnosis, and then based on that we would have made a clinical decision, and further on we don't move with the other further information that we have gotten. In our case, what had happened was we were fixated on the first information that we have got. It was the triglyceride levels that was done from outside. We were fixated on that information, and with the diagnosis that was told from outside, that is the chylothorax. And then with that, we had moved for the initial 3 days, and when on retrospection, only we were able to find out that it was not the right diagnosis. And this is not just here, it is more common in an emergency setup. In the medical emergencies also, it is a very common thing of anchoring bias that affects the physician's decision making. So, all these things said, and now we have to know about the standard protocols and guidelines that are there in our trauma centers that are there to be followed. So, whenever there is a patient who has presented to us with blunt trauma in a hemodynamic unstable state, the patient, there is no point of proceeding any further information. We will proceed the patient to an OR and for a damage control surgery. But if the patient is stable, we will have to plan for a contrast enhanced CT. It is either a single phase or dual phase based on the patient's requirements and the initial findings of the patient. The CT protocol in our center says we need to get a non-contrast CT of the head and C-spine, followed by a contrast enhanced CT of the thorax, chest, abdomen, and pelvis, with or without the other CTs like esophagogram, angiography of the limbs, as per the indications of the patient. In this case, if the patient had presented to us, and if we have seen a few of the findings like an esophageal wall thickening, a pneumomediastinum, or a mediastinal standing, if these were the few information that we have gotten, we would have obviously gone for a CT esophagogram, but that was not the case. There was one issue with this patient was he had come 5 days later from an outside hospital with the diagnosis and with an HRCT, which was not the recommended protocol for this patient, and it was not adequate also. So with that information, we had proceeded, and then we had missed an injury. This is the main reason why we need a standard protocol for imaging in trauma, especially. So, with all this discussion, we would like to conclude that our protocolized management strategies are key to prevent all these missed injuries. There needs to be high index of suspicion, not just with the information that we have, and with the nature of the injuries also. And radiological investigations should be carried out as per protocol, and always be aware of the existence of anchoring bias. And based on that, we should broaden our perspective, and our thought process should be on to find out whatever is not to be missed. And when we were studying about this missed injuries over here, I had come across a amazing line from a 1989 journal article. So it actually befits the entire purpose of this presentation. Instead of being disregarded as freak accidents or mishappenings by the inexperienced, we should believe that it should be looked straight into the eyes, it should be discussed openly, and to be analyzed honestly with an open heart. And this approach will result in a safer care and better care for the trauma patients. And we'd like to thank you for
Thank you, Rajesh, Srishti, and Puneet for nice presentation, and the house is open for discussion. Before we discuss, I would like to acknowledge the contribution of Dr. Anand from GI Surgery, who had undertaken this gastric pull-up procedure in this patient. And thank you, Anand. Would you like to say something before we start? Okay, thank you. Yes, sir.
I would like to congratulate you on shaking your hand first and secondly bringing up this case. I think this is a very important case and very honestly you have brought it up with a very good message that we all make mistakes. It is not that we don't make mistakes. But mistakes is very important, and I think it is not only just the injuries. We get the diagnosis every day. It's anchoring bias, not recorded to medial bias. See the patient and labels as they are anchoring. And that patient does not have an anchoring. I think recently there was a patient in our ward, 67, 68-year-old, very engaged patient. Somebody did a CT outside, diagnosis, injury, EUS outside, injury. But when I saw that CD and the MRCP, they all are existing. Even here, the US was running up. But when I saw the MRCP, did not look to be a injury. Discussed the case again with the and years again, and it was the same stone only. So this labeling business model is not entering bias, but the labeling. Somebody labels as some disease outside, that label carries on. We don't get carried away. It is not a bad idea to look at the investigations on, but I think do the investigation. I agree with one of the slides which is the radiological. The radiology does not do anything. No, it is
Interpretation.
if you don't tell them that you are suspecting it's a disease, they will not until unless there is something wrong.
Yeah.
So it is never a radiological lab. It is never an investigative lab. It is the interpretation only based on the commission, which is important.
Yeah, I do agree that whatever we are feeding to them, whatever we are telling to them, but
To discuss it with the radiologist,
yes.
then yes, one always come up with a conclusion.
And I think the youngsters who are sitting here, it is very important, like Dr. Bansal emphasized, to honestly accept your mistakes. Like if you have missed anything, do not hesitate or do not bring your ego into it. So all kind of cognitive bias, anchoring bias, they may be literary words. But the fact is that the patient should not suffer because of our non-compliance or non-adherence to the investigations. A last word from Dr. Atin regarding the radiological, because the radiology played a very important role here.
You already highlighted, and as Dr. Bansal also said, in our practice in the last 18 years since the trauma center is running, we've seen esophageal injuries due to blunt trauma very infrequent. Having said that, since you see it very infrequently, you sometimes feel or you miss actually when it like stares at your face, something a case like this. You have to have a clinical suspicion at mind and therefore do a specific investigation which is tailored to look for esophageal. If we start doing that specific investigation in all patients which we get, the yield is going to be low. It will have a burden on the time, efficiency, cost, everything. So that's what he said. If a clinical direct suspicion is provided, then this is, or of course, some radiological signs which do not fit with the clinical picture, then you specifically do that. And as said, when a definitive investigation of a CT cystogram, esophagogram was done, really relatively, but on day 10, then it was clearly shown. So we need to work in tandem with the clinical suspicion and the radiologist, and we contrast oral contrast only that shows
Yeah.
not having contrast. So the oral contrast is not in your product.
Until
Unless we specifically think and want to rule out.
Then we go for
Esophageal injuries are way more commonly in penetrating injuries or hypergenic or procedure-related injuries rather than blunt thoracic injuries, which occur once in 6 months, 4 months, 5 months, 7 months down the line. So you have to think and discuss and only do that specific investigation to rule that.
So multi-specialty involvement, all kind of specialties sitting together and brainstorming on the management of the patient is again highlighted. Any other comments? Yeah. I think over last 20 years, we've had 4 or 5 cases of chylothorax, and interestingly, 3 of them have already been published. One was interestingly was managed by the glue therapy. So that yeah. Yeah. Right sided. All were right only. One was left. Yeah, that. That's why everyone got flown by that.
So maybe that is also thing. Now there are 2 injuries. One
Yes,
is overshadowed the
yes,
other.
Yes, yes.
Seeing one injury does not mean that you do not look at the second injury.
Yes.
So typically we see a lot of pneumomedicinum with blunt thoracic trauma. The most common cause for pneumomedicinum and blunt thoracic trauma is air from the alveolar injury. Pneumothorax, alveolar injury, interstitial air coming in pneumomedicinum. So, or a airway injury, rarely. Esophageal injury is not going to produce a significant pneumomedicinum. It will only produce a very localized pneumomedicinum, just at esophagus will not have that much of air to lead off to the air into the pneumomedicinum, subcutaneous emphysema. That much amount of air is always going to come from the airway. Esophageal injury will have air just localized close to the esophagus, as well as mediastinitis evidence also, which will be fluid also. Esophagus will have fluid as well as air, not just air. Airway injury or alveolar injury will only have air. If you see fluid around the esophagus or air combined, we then specifically want to do a CT.
Thank you. Thank you, everyone.